Swayam Prabha. Digital India. Educated India.
Hello everybody, good afternoon. I am Professor Vikas Medi. Today I am going to talk about antihypertensive agent. Now, I have couple of questions for you. Do you consider hypertension is a disease, or it is because of that it causes the whatever incidence of morbidity and mortality, it's because of increased hypertension. Now, moment you say hypertension, it is you can define hypertension as you look at the systolic blood pressures or you look at the diastolic blood pressure. Now, if the systolic blood pressure is more than 130 or diastolic blood pressure is greater than 80 millimeter mercury, you can look at the different guideline, NICE guideline, GNC 8 guideline or American Heart Association guideline. All this it talk about that you define hypertension looking at systolic and diastolic blood pressure, if it is beyond 130 or 80. Now, question here, if person is not having a normal pressure, normotensive, then the question is the incidence of morbidity and mortality is significantly high, and that is the reason that it need to be diagnosed at early, and in case of hypertension it should be properly give the management on treatment. Now, again we go in detail about American Heart Association classification. Look at the blood pressure. You consider normal if the systolic blood pressure is less than 120 or diastolic blood pressure is less than 80 millimeter mercury. Once it is more than 120 to 29 or diastolic is high beyond 180, it is called elevated, and that is also we divide it into stage 1 hypertension. Like if you find blood pressure is 130 by 139 and diastolic is 80 to 89, you consider it is a stage 1 hypertension as per the American Heart Association. Then stage 2 hypertension you call it if it is beyond 140 or it is high and diastolic is more than 90 millimeter mercury. It is called stage 2. So, in case of a hypertensive crisis, person usually have more than 180 systolic, or in hypertensive crisis it is go beyond 220 and diastolic is more than 120. That means, in case of a hypertensive crisis you have to give the emergency treatment for management of hypertension. So, as per this American Heart Association classification, you have normal, elevated, you mark it as stage 1 or stage 2 or hypertensive crisis. Now, as you know that blood pressure is nothing but it is a cardiac output, you can multiply by peripheral vascular resistance. Now, it is you need to also understand in great detail about physiological regulation of blood pressure. So, that means moment to moment the regulation at the arterioles or post capillary vessels or in a heart. Now, most of the time you say that 90% of the cases you do not know the etiology of the heart blood pressure. So, you call it a essential hypertension. Rest of them it is because of something wrong in the kidney or you call it renovascular. So, there are reflexes you need to study physiologically like baroreceptor reflexes which regulate, or there are lot of vasoactive substances get released which regulate the blood pressure along with cardiac output and peripheral vascular resistance. Now, depending on the pathophysiology, we have several drugs. The older drug you talked about is diuretics. It is most cheaper one, most efficacious like diuretics like thiazide diuretics, we have a hydrochlorothiazides or chlorothiridine or indapamide. And among these diuretics, we have a high ceiling diuretics also, for example, furosemide or furosemide. And we have potassium sparing diuretic like spironolactone or amiloride. Of course, we have a newer version like eplerenone, potassium sparing diuretics. Second group of drug is commonly used is ACE inhibitors, angiotensin converting enzyme inhibitors. Like there are several ACE inhibitors, we can take some are prodrug like captopril, enalapril, lisinopril, perindopril, ramipril, fosindropril. So, there are a lot of ACE inhibitors are there. Then we have a drug targeted one is it is only act on angiotensin receptor blockers. Most commonly used angiotensin receptor blockers are losartan, candesartan or irbesartan, valsartan, telmisartan. So, there are lot of ACE inhibitors are there. Then we have a class of drug which causes direct renin inhibitors like aliskiren or commonly used drug which is day to day life we use is calcium channel blockers. For example, we start with amlodipine, verapamil, diltiazem and nifedipine, felodipine. So, there are varieties of calcium channel blockers are used and another group of drug is beta blockers. So, we have a beta blockers which is selective beta blockers in beta 1 or beta 1 and beta 2 also there like for example, propanolol, atenolol is selective, metoprolol selective, labetalol. So, there are varieties of example of beta blocker class. Now, along with beta blockers as I said that there is a drug which block beta and alpha receptor like labetalol and another group of drug we call it vasodilatory beta blocker which is commonly used nowadays practice in congestive heart failure like carvedilol. We have also alpha adrenergic blockers like these are very potent antihypertensive agents. It block alpha 1 receptors like prazosin, terazosin, doxazosin, phentolamine or phenoxymine. So, this phentolamine or phenoxybenzyme particularly used for pheochromocytoma because it is irreversibly inhibited. The binding is irreversible with alpha receptors. Then we have a drug which act on centrally mechanism. For example, we have a clonidine, we have methyl dopa which is act on presynaptic receptor, alpha 2 receptor has a agonistic activity. Then we have a class of drug called vasodilators. So, there are some arterial vasodilator like hydralazine, minoxidil, it is minoxidil because of vasodilatory properties it causes hypertrichosis, it is used for hair growth or diazoxide or there are drug which causes dilatation of artery and venules like for example, sodium nitroprusside and this drug is used for in case of hypertensive emergency. Now, as you can see that we have a drug which directly inhibit the renin. So, one of the drug which is we discuss is aliskiren is only available member in the latest class which is renin angiotensin that system is inhibitors and it is act by blocking it has a catalytic activity. By inhibiting what it inhibit is production of angiotensin 1 and 2 and as you know that angiotensin 2 is a potent vasoconstrictor. This drug usually report that ADR is reported it causes diarrhea and specially diarrhea is reported when it is given in higher doses and also can cause cough and one has to be very careful because it also causes angioedema. So, in case of anaphylactic or allergy or hypersensitivity one has to be careful that some people develop angioedema and probably when you compare with ACE inhibitor it is less with direct renin inhibitor. Now, coming back to ACE inhibitor very commonly used. Now, why this drug is more potent is because it causes decreased peripheral resistance. So, that is how it lower the BP and it also promote natriuresis, sodium level is excreted. So, in case of a patient suppose patient is suffering from diabetic nephropathy or congestive heart failure or left ventricular hypertrophy, it is usually a drug of choice, because it inhibits sodium and water excretion, and also it also help in potassium retention. Now, for example, if you look at the figure, so there is an enzyme angiotensinogen. So, you give renin inhibitors which block the formation of renin, and ultimately what you see is there is a decrease, like it is cannot convert from angiotensin 1 to 2 because of angiotensin converting enzyme is blocked by AC inhibitor. And at the same time, if you see aldosterone production, if it is decreased, then ultimately output of sympathetic activity is decreased, and at the same time it causes vasodilatation, and also the retention is also interfere with the retention of sodium and water. So, that is how it has a potent antihypertensive agent with AC inhibitor. Now, indication for AC inhibitor is, one is hypertension, or use for congestive heart failure, or in case of a myocardial infarction, or in case of scleroderma crisis. So, these are the usual indication is hypertension, congestive heart failure, or myocardial infarction or scleroderma crisis. Now, when you look at or discuss AC inhibitors, captopril is the first AC inhibitor. As you can see, there are a lot of AC inhibitors are there, and this captopril or lisinopril are the active drug. Now, other AC inhibitor, some are pro-drug, and it get activated when it is hydrolyzed by hepatic enzyme. Like suppose, if you give enalapril, it converted to enalaprilate, or if you give ramipril, which is converted to ramiprilate. So, this the metabolite which is active metabolite, you get an effect. So, the bioavailability of active like perindopril, perindoprelate, it might have a interaction with food. So, you will not get a effect, except fusinnopril, which is eliminated by liver and kidney. So, all AC inhibitors are eliminated by kidney in the urine. So, current status, if you see that AC inhibitor in case of stage 1 hypertension with some of the comorbidities. So, this is considered as first line therapy if thiazide diuretics are not used, or in case of stage 2 hypertension, it is combined with thiazide diuretics. Now, in case of a drug of choice for hypertension, like suppose patient having a comorbid like type 2 diabetic mellitus, or left ventricular hypertrophy, or congestive cardiac failure, or post myocardial infarction in case of coronary artery disease, or chronic kidney disease, or cerebrovascular accident, then it is a drug of choice used for AC inhibitor. Stage 1, stage 2 with comorbid. So, you have a drug of choice. Now, coming back to angiotensin receptor blockers, very commonly used. As you can see that earlier angiotensin AC inhibitors, the common problem is a dry cough. So, if you look at the mechanism of action, how it differs from AC inhibitors, basically angiotensin receptor blockers, that there is no interference with bradykinin. So, if you look at that incidence or people suffering from dry cough, so because there is no degradation, so there is less chances of dry cough. And these ARB inhibitors, it completely inhibit the AT1. So, it causes receptor activation, or there is also effect on indirectly on AT2 receptor activation. It can be used in similar condition like AC inhibitors. Only ARB is reported with mild headache. Some people complain of dizziness, weakness, or upper GIT problem, or there is a problem that in case of pregnancy it should not be used like AC inhibitors. It causes interference. So, there is chances of teratogenicity with this drug. Now, what are the example of AC ARB inhibitors? ARB is losartan is very commonly used. Then we have a drug called valsartan, irbesartan, candesartan, or telmisartan. Now, if you look at this drug, as it do not produce bradykinin, so advantage is that there is a less chances of cough, or if there is any chance of angioedema, it is less compared to AC inhibitors. Particularly losartan produce active metabolite and it has an antiplatelet activity due to competitive antagonism on thromboxane. And among these losartan, valsartan, candesartan, telmisartan has a longer acting drugs compared to other ARB. So, this is the first line agent for treatment of hypertension, especially when the patient complaining of indication that patient hypertension with diabetes or patient hypertension with hepatic heart failure or in case of a chronic kidney disease, then it is considered to be first line therapy. Though the ARB should not be combined with ACE inhibitor, the reason behind for the treatment of hypertension due to similar mechanism and adverse effect, because it will enhance the untoward effect. So, it should not be combined. So, this agent is a known agent for teratogenicity. So, it should be avoided in case of a pregnancy because of teratogenicity. Second thing is angiotensin II is converted to in the efferent arteries by generating the back pressure in the glomeruli and it can lead to injury. So, by reducing the angiotensin II, this should reduce the renal injury or risks. Now, what is the current status? Current status, if you see that as a alternative to ACE inhibitors, or you can say intolerance, some they develop hypersensitivity, some they cannot take it because of chronic dry cough. So, you can have an alternative one. Now, only important option in patient in concurrent disease like heart failure, congestive heart failure, in case of stroke or patient with diabetic mellitus. Some of the newer drug you can say that aziceraton or medoximil, which is approved in 2011 by US FDA, and in India since 2017 it has been available. Now, there are some dual ACE inhibitor or norepinephrine inhibitor also, like you can example of semaglutide, omapatril, gemupratril, mixenpril, physinobil. There are a number of compounds are available, which are a dual inhibitors and NAP inhibitor. Now, let us discuss about most commonly used drug in day to day life is calcium channel blockers. As you see that calcium channel blockers are recommended for treatment option of hypertensive patient along with diabetes or angina. There are several advantages of using calcium channel blockers. Like for example, if you use beta blockers, the common problem is fatigueness. So, you cannot select for a young patient. So, in case of high dose due to risk of myocardial infarction, like short acting, it is not preferred. We have a diparacetamol which block L type calcium channels in vascular smooth muscle. Like for example, we use amlodipine, felodipine, nicardipine or nifedipine. Then we have non-dihydropyridamole, which is non-selective calcium channel blockers like diltiazem, verapamil. It inhibits the calcium channel blockers in SA node and AB node. So, what it does is it causes decreased contractility, it reduces the heart rate or it inhibit or reduce the SA node to AB node conduction. So, these are advantages with calcium channel blockers. Now, how it acts? Basically, it is important to maintaining the tone and contraction of the muscles. So, what happens in calcium enter the muscle cell through special voltage calcium channels and it trigger the release of calcium in sarcoplasmic reticulum. So, these are the mechanism of calcium channel blockers. So, therapeutically useful in case of treatment of hypertensive patient, especially those patients with hypertension with bronchial asthma. As you can see that beta blocker are contraindicated, or you can also use in case of hypertension with patient having peripheral artery disease. So, most of the drug we use is diltiazem, verapamil, or these two drugs is also used in case of atrial fibrillation. One of the common cause of untoward adverse effect with calcium channel blocker is constipation. and this constipation has been reported with calcium channel blocker like verapamil or diltiazem. So, avoid in a patients of in case of a AB block, atrioventricular block, as you see that it decrease the conduction. So, it should not be preferred in case of a AB block, because it has a negative inotropic effect, that force of contraction of the muscle is decreased, and also it has a negative dromotropic effect. So, velocity of conduction of SA node to AB node is interfered with this calcium channel blocker. So, it should be avoided. Now, in case of a nifedipine or other dipyridamole, it also reported that it can cause phenytoin like reaction like gingival hyperplasia. Now, advantage with this calcium channel blocker is, as I already said, that it is not going to interfere with the physical activity. So, person can perform a normal physical work, it does not cause sedation, it do not have any renal perfusion impairment. So, it can be used in a kidney disease also. It is not interfering because it is only calcium channel blockers. So, in case of a hypertension with bronchial asthma, angina or pregnancy, it is safe, or in case of some problem with electrolyte or plasma lipid. So, lipid profile is not affected by calcium channel blockers. So, currently it is used because it has a negative inotropic or worsening the concern in case of a congestive heart failure or cardiac congestion, or it is have a relaxant action worsen, or it might affect in GIT reflexes, or some people they have a problem in voiding the bladders. So, those patients having a prostatic hyperplasia, of course, you need not have to give this drug, because it can interfere with bladder voiding. Now, coming back to another important group of drug is alpha 1 blockers. As you know that alpha 1 blockers, alpha 1 receptors, they are mostly in the vascular region. So, if you block alpha 1 receptors, definitely it will act as vasodilator and it will act as an antihypertensive. Of course, these drugs are also used in condition like prostatic hyperplasia or benign prostatic hyperplasia. So, some of the drug you can see that doxorubicin, prazosin, what it does is it block alpha 1 receptor in vascular smooth muscle. So, it causes decreased vascular resistance, and that is how blood pressure it comes down to the normal blood pressure. Now, another group of drug is beta blockers. As you can see that we have selective beta blockers and we have combined effect on beta blockers, beta 1, beta 2 and alpha blockers also. Now, you take an example of selective beta blockers. Most commonly used selective beta blockers is atenolol. It acts on beta 1 receptors metoprolol in the heart. So, it causes decreased cardiac output and BP is normalized. Similarly, non-selective beta blockers like it act on alpha plus beta. So, we have labetalol, we have carvedilol, it block beta receptors in the heart and the kidney. So, there is a decreased release of renin. So, it causes decreased cardiac output and normalize the blood pressure. Now, look at the centrally acting adrenergic drugs. I have already said the centrally acting, like you can take the example of methyl dopa. We can take an example of clonidine. Basically, it blocks sympathetic output in the brain because it acts on presynaptic receptor alpha 2 receptor, it has agonistic activity. So, if you give a drug like clonidine and methyl dopa, since it has agonistic action, so once it stimulates, there is a decreased norepinephrine is released from the central activity, and that is how it decreases the blood pressure. So, it produces a negative feedback of catecholamine production and release, and that is how there is a decreased cardiac output and decreased BP, and especially methyl dopa such as active, it is converted into methyl epinephrine. So, these two drugs are used in hypertension emergency, and but only thing is that you have to think of a tolerance, and methyl dopa is specially used for pregnancy. Now, what are the side effects in case of a centrally acting is patient specially reported with dry mouth, drowsiness, some people they complain of constipation and sedation, and others like common side effect is headache, nausea, sleep disturbance, some people also develop skin rashes. Now, if you look at the current status, we have a newer beta blockers that it causes vasodilatory property. We call it vasodilatory beta blockers. For example, most commonly used vasodilatory beta blockers along with why it is used, because it has also antioxidant property like carbidopa. It causes decreased mortality, it causes decreased morbidity in patient with heart failure or in patient with acute myocardial infarction. This drug is better tolerated and they do not have increased diabetic mellitus and weight gain. Another drug has been used as a vasodilatory beta blocker is nebivolol, and this has been recently approved that it is a beta 1 blockers, and along with that it has a nitric oxide enhancing effect, and since it releases nitric oxide, it causes vasodilatation. Otherwise, we have a drug which is act on dopamine beta hydroxylase inhibitors like etamicastate. So, these are the newer drug has been in the market. Now, just see the role of vasodilators. If you look at the vasodilators, basically what it does, it opens the potassium channel and after that it releases the nitric oxide, it also blocks calcium channels and also act on calcium channel receptors. So, all the vasodilators, it can have a reflex tachycardia, because once there is a vasodilation, there may be simultaneously increased heart rate. So, reflex tachycardia, and due to vasodilation, sodium and fluid retention is occur due to compensatory mechanism. So, based with diuretic with beta blockers, or even if you see following that patient reported with tachycardia and it might also have, because of vasodilation, it can have headache. One of the drug you can see bosentan, and this bosentan is basically a competitive antagonist to potent vasoconstrictor like endothelin. Like when you say vasoconstrictor, you can say adrenaline, you can say noradrenaline, or you can say that most potent vasoconstrictors are endothelin. And that is the reason that people have developed the drug like bosentan which act on endothelin 1, and this endothelin A and B receptors, it is located in pulmonary vascular cells. So, this drug is used, it is a potent vasodilatation. So, it is used for pulmonary drug of choice for pulmonary hypertension. It is very difficult to treat in case of a pulmonary hypertension, and this is only drug which is used in pulmonary hypertension, which is an endothelin antagonist. Second drug is feludepam. It is a D1 receptor antagonist, and if you look at the receptor locality of D1, it is mostly in a smooth muscle or peripheral vasculature or in a mesenteric area. So, by stimulating D1 receptors, it causes vasodilatation in periphery. So, there is a decreased peripheral resistance. So, BP is normalized. At the same time, this drug also causes inhibition of sodium reabsorption, because it causes natriuresis and diuresis. So, it has a rapid action, though it is a short duration of action, or in case of emergency you can select this drug for management of the patient. Now, one of the drug which I already said that we use for hypertensive emergency, because it is a potent vasodilator, like for example, sodium nitroprusside or nitroglycerin. It is a source of nitric oxide which causes potent vasodilatation, and that is how if the BP is very high, hypertensive emergency. So, this is the drug which used at the emergency purpose. Now, some are directly acting as a muscle relaxant, smooth muscle relaxant in the vessels, though hydralazine is a potent vasodilator. Of course, there is no clear mechanism of action, but another drug you can say that minoxidil. Now, minoxidil what it does? It basically stimulates to opening the ATP block potassium channel in a smooth muscles. So, because of that there is a vasodilation properties, and it lead to stabilization of less vasoconstrictor, and it decrease the peripheral resistance. and this drug is also used with diuretics and beta blockers. Now, one of the ADR with this drug is reported that it is causes hypertrichosis. So, now people have developed a topical application which can be used in patient with less hair for hypertrichosis, for excessive hair growth. Now, coming back to the basic drug diuretics. In case of diuretics, we have thiazide diuretics like for example, hydrochlorothiazide, and these thiazide diuretics can be used as an initial therapy for hypertension. Now, why it is been selected? Because it reduces sodium and chloride reabsorption. So, it lowered the blood pressure initially, increasing the sodium and water excretion. This is also given in combination with other antihypertensive agents, but it is not been preferred if the patient is suffering from kidney disease. So, initially it should be used with a low dose, then you increase the dose. Now, another example of diuretics is very commonly used diuretic is loop diuretics, furosemide or furosemide. This drug is safe compared to thiazide. Thiazide you do not prefer in kidney disease. Is safe in kidney disease patient, but it is not indicated in mild to moderate hypertension. Now, one example of endocrine, the patient with a gout, like it reduces the reabsorption of uric acid. So, we have a potassium sparing diuretic like trimethoprim or spironolactone, and it also help in potassium and sodium exchange in kidney, used only in combination with thiazide diuretics or loop diuretics due to its side effects. Second is what you do in hypertensive emergency. As you can see that blood pressure is more than 180 systolic or go beyond 220. Similarly, in diastolic also it is increased. So, in case of a hypertensive emergency, you start with thiazide, but in case of a hypertensive emergency, like we give thiazide in case of hypertension, but in case of hypertension emergency, we have a calcium channel blockers. We use nicaradipine or clebidipine, but in case of a gestational hypertension, like in pregnancy, the drug of choice is methyl-dopa, or it can be used labetalol orally, or in case of hypertensive emergency in pregnancy, the drug of choice we give labetalol intravenously. So, these are the options are available for hypertensive emergency. Now, look in detail about gestational hypertension. Basically, in gestational hypertension, what happens? There is a reduction of ureteroplacental circulation or perfusion, and it is because it leads to placental ischemia. So, once the ischemia develops, there is a activation of maternal vascular endothelium. So, it causes increased release of endothelin, or there is a sensitivity, increased sensitivity to angiotensin II, and that is the reason there is a role of decreased formation if you give the drug, that it causes vasodilation. So, if you summarize the antihypertensive drug, like what are the conditions you will use going for a diuretics. For example, diuretics like thiazide we discussed, chlorothiazide we discussed, hydrochlorothiazide, indapamide or metalogen. So, these are drugs are used in case of a hypertensive one, patient mild to moderate hypertension, or hydrochlorothiazide in case of nephrogenic diabetic insipidus, or indapamide we use acute pulmonary edema or hyponatremia, or metalojuman in case of a hypocalcemia. Similarly, if you take a second class of drug, if you talk diuretics is the first choice, second class, if you see beta blockers, we have selective beta blockers, we have non-selective beta blockers. Take an example of atenolol. Atenolol we use that it can cause bradycardia or an AV block. We are not going to prefer atenolol, or bisoprolol, metoprolol. These are the drugs are used, but it is not preferred in a patient with bronchial asthma, or in a patient with psoriasis. You are not going to prefer the beta blockers along with that. Look at alpha 1 blockers. It is used in hypertension like doxazosin. It is also used in some other condition like benign prostatic hyperplasia or migraine. So, one of the newer alpha 1 blocker is alpha 1 D subtype receptor, it is inhibited is tamsulosin. Similarly, we have a centrally acting drug which inhibit the central sympatholytic action like methyl dopa preferred in pregnancy, clonidine it is preferred in hypertension, or we do not use right now is reserpine or guanfacine. Reserpine was initially developed, is a very good antihypertensive, but later on it was withdrawn because it causes lot of suicidal tendency. So, it is not used in clinical practice. Now, most common clinical practice we use is drug like amlodipine, calcium channel blockers, or nifedipine, or clebidipine or nitropyrin. Amlodipine is most commonly used. It is used in hypertension, angina, or only the problem with amlodipine that it causes pedal edema. It causes pedal edema. There is a swelling of the ankle with calcium channel blockers. Other drug we use is SE inhibitors, like you can take an example of SE inhibitors like initial drug is captopril, and there are several pro-drug which actually converted to metabolite, active metabolite we get an effect like enalapril, ramipril, we have several examples. So, these drugs are used in hypertension, heart failure, or hypertension with comorbid conditions like diabetic mellitus. Second thing is we have ARB, angiotensin receptor blockers, like for example, we have common drug is losartan or candesartan or irbesartan. There are several drugs are there. Okay. So, along with this has a longer acting, it is a longer acting drugs with ARB, telmisartan. So, this is used in hypertension or heart failure, or in case of there is a target organ problem like diabetic nephropathy. Okay. So, these drugs are used commonly used. Now, we have a directly renin inhibitor like aliskiren, it is used in hypertension, and it has an advantage that it do not cause like ARB, it do not cause a dry cough. So, as you see that in antihypertensive, it is not a disease, but we have to control the pressure, blood pressure in order to decrease the mortality and morbidity of several diseases. So, drug we have several drug depending on that. If you summarize that we have diuretics, we have beta blockers, we have alpha 1 blockers, we have centrally acting sympatholytic, we have calcium channel blockers and SE inhibitor or directly renin inhibitors. Now, depending on mild to moderate hypertension or hypertension with other comorbid disease like diabetic mellitus and other disease, we select like if you want to treat hypertension of a young persons, essential hypertension, you need to select the drug if it is beyond 60 years. So, depending on the condition you have to select, like for example, you can select a drug of calcium channel blockers, it is not going to interfere with physical activity. If you see that patient with hypertension with bronchial asthma, you are not going to prescribe beta blockers. We have several other drugs which will not interfere with beta 2 activity. So, depending on that you have to select the drug, and so that we can have a safer drug therapy, we can manage the patient well, and you can decrease the mortality and morbidity over a period of long duration. So, if you have any question, please discuss and put the question for further discussion. Thank you very much.